Good afternoon, everyone. We will start this seasonal risk forum with some closing remarks and present some future direction. I will give the floor directly to Lorenzo Merlini.
Yeah, good afternoon, everyone. Thanks once again for being here. So we'll start this seasonal risk forum by closing this fantastic November risk arthroscopy course. We've been very happy to have you here. It was a special course for us because it was actually, as Christophe said it at the beginning, the 50th risk arthroscopy course in Strasbourg and the 100th IRCAD-IWC course in the whole world. So it was a special course, and thank you for making it so special as always. So thank you for the participants for their motivation and their presence, and thank you for the faculty and for the friendship as always with probably the most important ingredient of the recipe. And with that, I will let Alam tell us what the future holds for us.
So once again, thank you. We were very happy here to have you. Some of you attended the basic course, the others the advanced, and at the top of the mountain we had the master course. And of course, the journey continues. It's not the end of the adventure of our relationship. So as you know, the format of our courses are really special. We have a smooth learning curve. So we have the basic, the advanced, the master course. So if you attended the basic course, for example, if it's very important when you go home to practice, wait a little and come back to practice on more complex procedures. And after you can practice more and more after the advanced course, and you can attend at the end when you you feel comfortable with risk arthroscopy, the master course, which is very special because it is a higher level with very deep debates and very advanced techniques that we practice in the lab. So here is an example. For example, we have Abdelrahman here that visited us in Paris. The adventure started 2 years ago, and he did all the steps of the courses. We know him very well. He's inside the family now, and it was his first participation. Congratulations, Abdelrahman. As a faculty, he was just outstanding. So in between the courses, we stay connected, of course. We have an online continuous education program. First, we organize webinars twice a month. The Clinical Cases Symposium is very important to us. We organize this with Lucian, Gustavo Gomez, with Shihab Taleb, with Lorenzo. It's interactive, free webinars. We discuss just like we are going to do this afternoon, clinical cases. And we have all the international research centers that are involved. It's very, very interesting. So you are all very welcome to join. And we have also now the Regional Club with a new team that will be organizing this once a month. So please, you can follow us on the social media and on the International Risk Center and IRCAD-IWC website. So we have also the ebook. I would like to remind you this. It's very important. It's free of charge. You can upload it, and it's an open access. We update it regularly every year with new techniques. And also something that is very important to us, the risk-based camp educational program. There are 7 steps in this risk-based camp. You had an email before this course, so you can, if you didn't complete the whole risk-based camp, it is you can do it after. So what's new in 2026? We had a lot of discussion during this meeting because all the experts are here for this course. So we had discussion especially with Pedro Delgado, the president of the IWAS 2026, and Stephen Moran, our general secretary. And we have this big event in 2026, which is the IRCAD-IWC IWAS diploma in collaboration with the IWAS, and Pedro Delgado will probably send a newsletter in December to announce it officially, but you need to know that it's very important to have validated some courses, especially in the IRCAD or in Madrid, to be able to attend this very first risk arthroscopy diploma. So as you see, we need to stay connected with the update for the updates on the social media and also on all the newsletter. It will be the big event of 2026. Also, you know that IRCAD is expanding worldwide. That will be the end. And after India, that we launched the very first course in India last October. And in October 2026, we will have the very first IRCAD-IWC course. It will be a wrist arthroscopy and ultrasound course. And that is what we will have in 2026. So once again, many thanks to everyone, to our partners, to the IRCAD teams, WebSearch, and please stay updated, stay connected with us on the website and on social media. Thank you. So now we we give the floor to the Seasonal Risk Forum. Thank you.
Enjoy the forum. Thank you.
Thank you.
Thank you very much, Ahlam. Thank you, Ahlam and Lorenzo. And now we have a talk from Professor Liverneau, AI in wrist arthroscopy. So we are all very interested. It's a great pleasure to have you here and to talk about this very, very current topic. Thank you.
So thank you, Lorenzo and Ahlam, for your kind invitation to give this lecture. You asked me to give this lecture about AI in wrist arthroscopy, but I added the word the future because let me warn you guys, if you're expecting a revolution already underway, you might be a little bit disappointed. AI in wrist arthroscopy is truly at its very early stage, but it's precisely what makes the topic very exciting. Everything still remains to be invented. So, first of all, how can we define artificial intelligence? It's difficult to give a single precise definition as it is a broad concept. You can see here AI is the ability of machines to perform tasks that normally require human intelligence. But what is human intelligence? So a useful way is to understand it through 3 increasing levels of complexity. And here on this slide is the first level. The first is a very simple rule-based systems. You fix instructions like if something, then something. So it's automation without learning. Second step, which is a little bit more complex, is machine learning. So the system learns patterns from data, like linear, logistic regressions, decision trees. So it improves with experience. And the last one, deep learning. So it's neural networks which are able to recognize complex structures. For instance, convolutional neural networks, like CNN, we call that, for images. It's closer to human-like perception and abstraction. But if you use deep learning, you have to know how to evaluate it with some metrics. So in a few words, accuracy is the total proportion of correct answers. Precision, among predictive positive, how many are correct. Recall, among true positives, how many are detected. F1 score and DICE, it's trade-off between precision and recall. Specificity is the ability to correctly recognize negatives. I won't go into the details of the equation, of course. The targets on the right side of the slide are much more illustrative. For example, the one on the top, you can see that it is very accurate and very precise. The second one, it's very precise, but it's not accurate. Third one, it's very accurate, but not so precise. And the last one, it's not accurate, it's not precise. So we will divide this talk in 3 parts. First of all, the benefits, then the risks, and then the most important one, how to balance that. So among the benefits, probably a lot of you know how we can use AI in diagnosis accuracy, in surgical planning and assistance, before the operation, during the operation, and after the operation. Then robotic surgery, and of course, it's usual for education and training. So this is an example for diagnosis accuracy. Here it's an algorithm that we designed here in Strasbourg University to automatically detect isolated peroneal net dislocation in frontal radiographs inspired from Gilles carpal arcs. Of course, for you it's very easy because you are hand surgeons, but for emergency doctors or young residents, it could be more difficult. So an algorithm can help them. This algorithm operates in 3 stages. First of all, the algorithm has to identify the carpal region. As a second stage, it should be able to segment an area enclosed by the Gilles arcs number 2 and 3. We call that the Gilles crescent. And as a final stage, it gives a probability to the segmented region to be normal or pathological, together with an uncertainty, a value, as well as a label predicted from these values. I will not go into details because it would take a lot of time. Only examples. This is an excellent example. And this slide shows how AI is trained and applied for diagnostics imaging, in this case, with X-rays. So on the left, you can see the workflow. More than 12,000 radiographs were collected from this hospital database. It's not in Strasbourg. You can see at the bottom of all the slides the papers. And they were carefully annotated by experts and then divided into a training set and a test set. So the deep learning model was then trained to recognize the fractures automatically, as you can see here. Of course, it's obvious for us, but sometimes it's not, especially for scaphoid fractures. So this slide shows how AI can help to detect the scaphoid fractures. So on the left, you can see the different steps of developing the algorithm. First of all, segmenting the scaphoid, then localizing the area with a bounding box, then cropping the region of interest, and then using a CNN to estimate the probability of a fracture. And on the right, you can see the heat maps where they show the model, where the model focuses its attention. So as you can see, the AI correctly here highlights the fracture zone in most cases, providing evidence that supports the diagnosis. So here about King-Buck disease. So this slide shows how AI can assist in identifying King-Buck disease on wrist radiographs. On the left, you can see the full patient selection and data preparation workflow, from exclusion criteria to the creation of a training and a test sets. So on the right, the images show automated segmentation of the lunate and the surrounding structures, helping the model to detect early signs of avascular necrosis. Here, this slide illustrates how dynamic MRI can help us to understand the wrist kinematics in real time. On the left, the graph shows how specific measurements change with wrist angulation in both patients and healthy volunteers. So the healthy volunteers, the colors are green and yellow, and on patients with a scapholunate ligament tear, they are in red and in purple. You can see the difference here. And on the right, the MRI frames demonstrate the actual movement of the carpal bones, making it possible to visualize abnormal translation or instability. So here it's so for scanning pre-operatively, these slides illustrate how robotic assistance can help in the management of scaphoid fracture fixation. On the left, you can see the pre-operative CT planning. So the system generates an optimal trajectory for the K-wire, helping the surgeon achieve precise positioning. So, and on the right, you can see the robotic arm in action. So you just have to insert the K-wire with a surgical drill. There's nothing very complex to do. Now, peri-operatively. So this slide shows how AI can improve arthroscopic image quality. It's not only about focus. On the left, it's a knee here. You can see the original noisy and blurry input. So in the middle, it's an algorithm based on the UNet-based denoising architecture process, the image, and it removed noise and sharpened the key anatomical structures. And on the right, the output is, you can see that it's much clearer. It's allows better visualization during surgery. Also, preoperatively. So this slide is a work from Thomas Gregory from Paris. And this slide shows how AI can automatically identify anatomical structures during wrist arthroscopy. So on the left, you can see the segmentation network architecture. It's also a UNet style model that learns to recognize the different tissues. And on the right, you can see the output examples which show how the system labels each region in real time, turning to a complex arthroscopic image into a clear color-coded anatomical segment. So this is very useful for beginners. Postoperatively now, this is an algorithm that we developed here in Strasbourg University. So these slides show an early work. Now it's better and better. We use and we developed an MRI to automatically detect surgical phases in distal radius fracture fixation on videos. So on the left, we explored how 100 surgeons annotate the same surgical video, and this reveals that there is a large inter and intra-observer variability. We have to take that into account when we want to annotate videos for, for the development of the algorithm. And on the right, you can see an annotation interface that structures the procedure into identifiable steps. This is the basis for training an AI model. So the different colors, as you can see here, the one on the top correspond to the phases, and the other ones, very, very small, correspond to some actions. The very bottom ones correspond to screws. So for instance, you can see 7 blue little dots. These correspond to 7 screws. But if you look at the X-ray, you can see only 6 screws. So what happened? Why is there seven screws here and only 6 on the X-ray? You can see that the last one is during a phases, which is considered as be the verification phase. So that means that probably during the X-ray, during the use of the fluoroscope, the surgeon considered that one of the screws was not correct, too long, too short, or in the joint or whatever, so it changed. So in a glance, you can see exactly what happened during a surgery. You don't need to watch the entire video. So postoperatively now, so this slide shows how AI can track hand movements using only a standard camera like a smartphone. And the algorithm identified the key landmarks on the fingers and the palm, and this allowed to measure range of motion, for instance, and it can recognize different ages, skin tones, and environments, as you can see here. And so it could be interesting to get some measurement, automatically measurement for the patient, but this is very well known. But what is more interesting is to make the patient do the self-rehabilitation and to control it automatically. And now a few words about robotics. So this is a very old study that we performed here in Strasbourg. This illustrates the concept of robotic wrist arthroscopy. On the left, you can see the robotic setup, and on the right, the arthroscopic views, which shows, of course, what is inside the wrist. And the goal of robotics here is to improve precision and stability during wrist arthroscopy, and also to save a hand. If you have this robot, you don't need to hold the camera. So the last benefit is training and education. So like the wrist base camp here, we also developed with Dr. Obdane from Netherlands. This slide summarizes the key elements of the theoretical training in wrist arthroscopy: indication, patient positioning, traction, instrumentation. And on the right, you can see also the basis of portals, etc., so that the trainees must understand these fundamentals. So also another benefits about theoretical training. So it's quite striking that in the literature, generative AI like ChatGPT or Gemini, they always fail on the literature. They always fail the FESH examination. I mean the first part with a question, the theoretical part, and they all pass the American exam. So, and no one has questioned this discrepancy, but we did. So we collected a set of questions from both European and American exams, and we submitted them to ChatGPT, and we obtained exactly the same patterns of results. So why is European exam harder than the one of the US? There is a reason. Nobody asked this question. The reason is that in Europe, the European examination, there are multiple choice questions. And in the US, it's only unique. You have only one choice. So it's easier to make less mistakes if you have only one question. This is the result of this study. And this is also an old thing that we did with Ahmed Zemirling. He was here today. And here we present the first use of augmented reality in wrist arthroscopy. So it's a CT-based navigation system with a real-time tracking, which projects the instruments and the joint anatomy directly onto the screen and blending real and virtual images. So the system provides feasible and safe, improving spatial understanding and accuracy. So for training, augmented reality helps to bridge the gap between simulation and real surgery. And this is interesting for young surgeons to better master the gestures and understand how it works. So, okay, these were benefits. So what are now the risks? And probably if you like AI, you don't look enough into this very important part. So the risks are mainly data privacy and security, bias and inequity, and over-reliance on technology, and finally, regulatory and ethical concerns. So about security. This NHS case shows that the healthcare system remain highly vulnerable to attacks. And when it comes to medical data, this impact is enormous. So if we want to move forward with AI, it's important to strengthen the protection of this data. It's essential. About bias and inequity, this is also very important to understand. AI is not neutral. It reflects the bias of the real world. And in healthcare, that becomes dangerous. Some studies even show that medical chatbots can reproduce racial prejudices. It's an important reminder. AI does not correct our biases. even it can amplify them. About errors of our reliance on this technology. So the diagram on the left summarizes the entire process that leads to an AI algorithm: image collection, annotation, training, validation. At each step, errors can slip in. And as you can see on the image on the right, the model can then flag a false positive. Human, some of them, fortunately, don't fall into this trap. There is no fracture here. But the AI said that there is one. So, about regulatory and ethical concerns. So this slide reminds us that medical AI does not only raise technological challenges, it also raises major legal and ethical ones. The World Health Organization emphasizes the needs to regulate AI to ensure safety, transparency, and fairness. And on the right, we see that some experts are concerned. If an AI tool makes a mistake, who is responsible? The clinician, the developer, the hospital? This is a real obstacle to deployment. But some people, try to find solutions. And the prerequisites to restore the balance between risks and benefits is very important to take into account. So if we truly want to restore the balance between both, we need to set up strong conditions. The idea of this future summarizes what should guide the development of an AI in healthcare. F for fair, avoiding bias and ensuring equity. U for universal, models that can apply to diverse population. T for traceable, transparency in data and processes. U for usable, tools that are genuinely integrated into clinical workflows. R for robust, able to handle atypical or challenging cases. And E for explainable, means understandable for clinicians. This is very important to take that into account, and please don't over-rely on AI. So, how to monitor the balance of AI? Once an AI model is developed, you can't just let it run on its own. It needs continuous monitoring. The goal is quickly detect and drift when the AI starts to move away from the data it was originally trained on. The image on the right clearly shows the difference between normal in-distribution data and out-of-distribution data, which can disrupt the system. So we need some algorithm to restore the balance. This slide presents a 4-step roadmap. I will not go into details for developing AI. This is truly safe and useful in healthcare. Design, development, evaluation, and then deployment. Each phase comes with specific requirements involving stakeholders, controlling bias, ensuring security, testing the tool on diverse data sets, and finally establishing a strong governance once the AI is used in clinical practice. So I hope I didn't bore you. Thank you for your attention, and please come to the FESH meeting in Strasbourg in 2028, if I'm still alive.
Thank you very much, Philippe. I think there's really a lot of things to make us thinking about and a lot of needs. So is there some really burning question or comment on it? In the meantime, I would go for...
So if there are no question, I want to invite René Roger, my friend from Santiago, Chile. He's a very, very, very experienced hand and wrist surgeon, and he will present a very, very interesting case.
Thank you very much, Eva, Michelle, Chile. We have a case. I shoot this case when the traumatic. We have a male, 41 years old, work event production, dominant hand motorcycle accident, thumb and wrist hyperextension. The case treat discussion is in the wrist. Yeah, okay. The first question: what is the diagnosis?
If someone wants to join the discussion about your point of view on this X-ray, I think I will take the closest. Please, please give us your name, where you're from, the level of your course.
Hello, my
and
name is Lucas from Austria. Well, the carpus is dislocated dorsally compared to the radius.
We'd say in the X-ray and the AP view, do you see another injury or only dislocation in the lateral view? We
Fractured
need.
parts of the radius, I suspect.
It's possible.
Someone else, maybe? Lorenzo?
Someone else has another thing to say about the X-ray diagnostic?
The dorsally dislocated lunate, and there's a fracture line extending to the mid shaft of the thumb, and also the distal radius is also affected, the styloid process, I guess, and most probably the distal radial nerve joint is also affected.
Okay. The second question: what is the ideal study? For example, Peter? No.
Okay.
What do you think that is ideal?
I
will
think-
ask.
I think we need to ask participants. Amir, you are hiding. Please, please, Amir, please take the mic. Give us your name. What is your level?
Hi, my name. Do you hear me? My name is Amir. I'm from Israel. I'm doing a fellowship exactly in the middle of 2 years and a half program. So first of all, I would make a reduction, but then after that, I would do a CT scan for the rest.
Okay, my fellowship in the emergency room asked this CT scan and different projection. Is the same diagnosis?
Matt,
I think that is radiocarpal dislocation. Yeah. Okay.
any additional comment compared to the X-ray?
I don't think so. I mean, the styloid is fractured. Carpus is still dislocated. The DRUJ looks like it might be dislocated too. We don't have a full view of it, so.
We have clinical problem and trauma and X-ray, radiocarpal dislocation, CT scan, fragment in the radius, and dislocation of the carpus. This initial, or what is your first treatment in this case? This is my order about to my fellowship. In the first, when you treat and the patients in the first moment, where's your treatment? What do you think?
Closed reduction.
Okay. Initial treatment is emergency room is immobilization. What's your opinion? Reduction under anesthesia, fixation immediately, or immediately open surgery or arthroscopic surgery, surgery in general.
Maybe we can vote.
Emergency room, 3 a.m.
I think we must check for...
Who is for reduction?
Okay. I did well, man. Look, in this moment, my patient in the emergency room, 3 a.m. operate room, I see in the fluoroscopy, dynamic fluoroscopy, this instability. Okay, this is the dorsalization of the carpus and reduction and unstable in the position, and the AP fluoroscopy and dynamic fluoroscopy, we can see the instability and radial deviation, okay, and reduction. It's very important to know what is the anatomy, what is the physiopathology, what is the compromise of the ligament and the fragment. Remember that the key fragment is very important, where the insertion of the ligament on the radius is very important in this case. Can anyone classify the injury?
Any volunteers? Yes.
We have some volunteer here, just in the middle.
Hello.
Yes,
Yeah.
just.
I'm Rahul, work in Manchester, UK. So this is a radiocarpal fracture dislocation. Classically, in few classifications, Dumontier did one, 1998. Mudgal wrote on it. Most recently, we have done one with Randy Bindra from Australia. So according to us, this is type 4, when there's a small soft tissue both ways. The styloid fragment has gone back, so you have a short radiolunate off. So you have to repair the styloid that will fix your radioscaphocapitate, and short radiolunate repair rollerly should stabilize the wrist, but we can assess it fluoroscopically when we're doing it.
Really good, yeah. Okay. And this is the same pain. I thought the same. In the plan, what is the treatment option in the second step when I treat in the first step reduction? Okay, I put close reduction and immobilization is a good treatment with a cast, external fixation and definitive treatment. Close reduction and percutaneous pinning and definitive treatment. External fixation and different surgery. Open reduction and fixation with ligament to repair through the double approach. And close reduction and fixation with arthroscopic assistance. And literature says the partial fusion and primary treatment. The President, please.
Can I do a question? Do you think it's necessary to have a post-reduction CT scan?
Very good. This is my question for the initial treatment. Yeah, okay.
So immediately, just
stop, Pedro.
just René, to understand, to really understand clearly, just after the reduction in the middle of the night, you send the patient to the CT scan. You are lucky in Chile.
Yeah, and the second part of we have a divide of the treatment in first step and the second step. First step in 3 a.m. and the second step arthroscopy or all possibility of the treatment. Okay.
So maybe we can ask our friends from Manchester, what would you do, because you're the British school. We know we are very good in in trauma.
No, it's the same everywhere. The treatment would remain the same. Doesn't matter.
So the
question is, if I'm getting it correctly, you reduce it in the emergency room. I hope it got the close reduction. There's no carpal tunnel symptoms. After reduction, goes for CT scan, and we define the injury. Look at the CT scan. We plan the fixation next morning. That's what I would do in this case.
Okay. In the proximal slide, I show you what is the initial treatment in this direction. Okay, right? For the possibilities, the present case is the possibility you view what is the anatomy of the compromised anatomy. Is the question of the Pedro is in this line. Okay, is that, for example, in literature show only case reports in 20 or 30 years, case report of the treatment on the radiocarpal dislocations, and this review, for example, 31 years, the review, and 26 patients, and percutaneous fixation and several treatment, and the result, the functional result, this treatment by initial treatment and injury pattern is different, and Monet, 1985, divide on two types of the radiocarpal dislocation, and depend of we have a dislocation and with a fracture, without fracture, and without associated injuries or no associated injury, and the Montier to 2001. Small marginal fractures, dislocation, and pure dislocation. And the second type is a big style of big fragment. Yeah. Returning to the case, the option treatment, and in this moment, in the operating room, I put the one key wire in the right stylet and view the AP stabilization and deviation of the radial position, and lateral view, one key wire 1.0, yeah, stabilization of the trauma. What do you think, Pedro, with this stabilization and this classification, this?
Because all classifications you prepare, the Montier anyone, is based in the ligaments attached in the radial styloid. The basis is the radio scaphocapitate ligament or radiovolar carpal ligament.
Exactly, yes. I think in this moment, 3M, when I put the one key wire, the indemnity of this ligament for the fracture pass through to between the scaphocapitate and large radiolunate ligament is very important to know when I put the one key wire, stabilization of the system. Okay, very interesting. And when I looking for in the literature, what is the treatment of the radiocarpal dislocation? We need dorsal approach, volar approach. When you fix the radial styloid and the brief fragment, is sufficient on the stabilization in this zone. Okay, those palmar appear. Those no, it's not necessarily open for volar and repair for volar part when a stabilization in the first moment. 3M. This is the first treatment. 3M. Do you like? No.
We can ask our participant about the opinion.
Please. Give me your opinion.
Okay, we have a volunteer. I picked a volunteer.
Well, if I like it, or
you can be honest.
If you can comment.
I have seen better.
Thank you. No, sorry.
No, well, I don't know. I think that it's a starter, but I'm not quite sure if this is sufficient.
Would it be a definitive treatment for you?
I think for the steroid, maybe it could be enforced with another K-wire to start with, maybe to get a better compression to make sure that it's not loosened up. And for the two other K-wire through the distal radius, is it because of the SL rupture you have found?
The most important concept in this configuration of the stabilization is reduction of the radiocarpal. I think I don't know what is the compromise. I think what is the compromise ligament. I don't know what is the real compromise. Okay, the stabilization 3M after treatment, totally treatment. Okay. 4 days.
That's pretty good for a 3 a.m. fixation. I mean, that's not out. Middle of the night fixation. Yes. That's pretty good.
I say my fellowship put the key wide. This is the program or the plan when we receive these patients. For me, it's excellent. Okay, my fellowship. Yeah.
Rene, I would like to add that one comment from Teach for Your Fellowship. That the first step in the 3 a.m. with this case is control the damage, and I guess that probably your fellowship do the best, and I very comfortable with this.
Yes.
And then you have to send the case to the expert. But I think that the first mission is control the damage, whatever the best way you can achieve.
My fellowship, I received my congratulations.
Okay.
4 days after, I need a commentary with the faculties in this position. We have a radiocarpal dislocation reduction with monumentality, and we can see in this view, 6R view, we can see the styloid fracture and compromise of the, totally compromise of the scapholonate. In this moment, we need experience where decide what is the best treatment. Now, this is the second view, compromise complete of the scaphoid. We don't see the laxity of the lunate. It's very important to know this laxity and reduction and stabilization of the styloid with 1 KY guide of the cure. Put the screw is I like technique is insufficient and evaluate in the mid-carpal joint. Look the compromise of the scapholonate in this pass of the probe, the dorsal part, compromise of the insertion in the radial part of the dorsal intercarpal ligament. I think that the bony fragment in the volar part of the lunate is very important to know in the arthroscopic assistant when you see the bony fragment in the lunate or triquetrum. It's very important to know what is the 4 types of the perilunate injuries in this zone. This is possibility of the reduction of the instability. I think in this moment, this dynamic compromise is a theory. Evaluate the lunotriquetral is good, normal. I use the classification of the IWAS for the when a classification of the scapholonate injury. The question: what's the final diagnosis? In this moment, I need the experience. I think that is the first approach in the initial treatment is very good for fellowship and training surgeons. And the second step, I think that is important. How Lucian.
Abdelrahman, it's your first participation as a faculty. But
okay. I think I would say it's a transradial radiocarpal dislocation that went through also at some point through the SL ligament. That's the main injury I see.
What do you think the very good treatment for the scapholonate dynamic 3C or this
ACDR?
Scapholonate, yes?
Yeah. You can do. The scope is in. You already diagnosed it. You can do the dorsal capsular adhesive, the little enlarged one or the simple one.
Okay, and
Peter, he wants to.
For me, if it's acute and it's dynamic, I would probably just pass K-wires because the ligament is off the scaphoid probably with the DIC. So if you want to repair it, you've got to put an anchor in. I don't think a purely soft tissue procedure is going to work.
Remember that we have a power of the hilt in the initial 4 days. We have a power of the hilt, and like the experience of the older surgeons, what is the ideal treatment? Pinnings, capsuloplasty, reconstructions. Well, I think that this insertion of the radial part of the scaphoid is very important. The dorsal intercarpal ligament is the important in the reduction or the stabilization. I don't know whether the pinning is sufficient. What is your opinion? This is my final diagnosis.
So, René, if we look at the X-rays and the CT scan and the way the energy flowed, I think we're looking in a lesion that is very alike a perilunate lesion. So what I would do is fix the bony fragments that will carry the ligaments with it, and then if I still have instability, I would pin it.
Yeah. In the first moment, I think that is perilunate injuries on plint, similar plint. When I evaluate of the volar LT ligament is very good, and dorsal is very good. Insertion in the ulnar part of the dorsal intercarpal ligament is very good. I think that's the ulnar part of the carpus is good. I focus of the treatment is in the scapholonate, volar and dorsal. My problem is dorsal intercarpal ligament. It's not only a scapholonate, it's dorsal intercarpal ligament in the insertion and radial part.
You have a comment from Madrid, Fernando.
I think this is a radiocarpal dislocation, so
Also the radio scaphocapitate and long radiolunate are torn. You fix the bone, but in our experience, we also like to reattach the ligament. So that is important that in acute injuries, you are not making a capsule, you are reattaching ligaments or trying to heal because you have healing capacity. So the first message, especially for people that are not very experienced, is to put the bones in anatomical reduction. You can do that arthroscopically and then pin. And most of the time, that is enough because the ligament can heal if they are in a good position. The further step will be to reattach, and I agree, for reattachment you need an anchor and to put back the ligament. So in this case, I will fix this radial styloid, I will reattach the radiocarpal ligament, and also, because in radiocarpal dislocation we have two cases like this, is also the scapholunate injury. So I will pin, because it's acute, and maybe also a suture, but for reattachment, not for reinforcement and nothing else.
Yes.
So, yeah.
This is the conclusion. Is real is correct. I think the same. When you put stabilization of the radiocarpal dislocation is the first part. The second part is repair or treatment of the scapholunate injury. In this focus, pinning, capsuloplasty or reattach depends what stability you in the final procedure, final part of the procedure you have. Okay. Second question, the final. What is the ideal treatment?
We need a volunteer on the left side, because until now it was the right side all the time.
Don't start me about politics.
Okay.
Ali,
Stop.
Canada.
I think the ideal treatment is a bit what was done, so closed reduction in the emergency setting, temporary fixation with a cast, and then bring to the OR for K-wiring. Definitely assess any combined nerve injuries with those radiocarpal dislocations. I think given the final diagnosis, I agree with what has been said. I think the radial styloid fixation that is temporary would deserve a compression screw for stability. This would bring back the radioscaphocapitate to its anatomical position, make sure arthroscopically that the RSC is not detached from that fragment. And then given the combined SL injury, I think it deserves either a primary repair, as said, arthroscopically assisted, or dorsal capsulodesis if the ligament is not of good quality, and then pinning of the scapholunate joint and probably scaphocapitate joint to secure this SL injury.
The final decision of this treatment. Okay,
it's both a question and a comment. I think I agree. I'd probably do a carpal tunnel release at the same time, but on the CT there's dorsal fracture fragments off the distal radius, so the DRC is also detached probably. Is it necessary to fix that if everything else is stabilized?
When I saw in the radiocarpal view on the arthroscopic system is not compromise of the stability of this small fragment. The big fragment is the most important, okay? And I use in pedilunate injuries when I have in my team, I have a big compromise. I need a solid stabilization. I use the pinning, it's very good. In our experience, I put the solid stabilization, momentary stabilization is the concept the screw clamp, yeah? It's momentary. That in this patient I put the screw in the styloid. I the second put inside to the carpus. I put the screw 2.4 in the zone. Evaluate dynamic fluoroscopy. Where is the stabilization of the carpus with two techniques? With stabilization of the radiocarpal dislocation and stabilization of the scapholunate, and view in AP dynamic fluoroscopy, we can see a very good stabilization. Remember that momentary stabilization is not definitely. It's not the Russell or technique the reduction of the scapholunate with the stabilization with the screw. In the same surgery, second look, evaluate what is the stabilization in the mid-carpal joint. I put the probe it's very good stabilization of the dorsal and the volar part. In this moment, I decide now perform to the volar and dorsal capsuloplasty and reattach. Previous, I thought this necessary reattach another ligament, but in this moment I decided no. This is the final result. 6 months. We have the opportunity to see what is the result of the stabilization. Second look, 6 months, removal of the screw, and evaluate what is the stability of the scaphoid is very good. And in this moment, the final treatment, final compromise, this in the right videos and the screen we can see of the before and the treatment. This is the final result in the radius, 6 months. This is the final result in this scapholonate and range of motion. They're very good. With Dutch and PW is low. Dutch is 0. This is a movement. Minimal invasive surgery. Thank you very much.
René, I just have a question, please, for René and for the other faculties. To be really clear, how do you advise, how do we manage the palmar ligaments? Fernando, we reattachment or not? No reattachment, finally. Is there a consensus? What do you think about this?
I think that when the arthroscopy is advantages when I totally diagnosis of the all ligaments in the radiocarpal and the midcarpal joint in the volar and the dorsal part. The most important is to know where's the anatomy, the real and normal anatomy. Where remember that is in the trauma we have a synovitis and bleed. In this moment, when I put stabilization in different areas, when I see in this moment, for example, instability in insertion of the short radiolunate ligament or large, reattach, no problem. Mini open, reattach with anchor or mini open. So the treatment is when I see another ligament tear, repair. So, it's my concept.
Okay, thank you. So Fernando, for example, what would you do here? Because we need to understand, to see, to have different point of view.
Yes, no. I think with pinning most of the cases is more than enough because it heals. But the next step is to be able to reattach. I think if you reattach anatomically, probably that's better. So in this case, I will do volar radial portal, put two anchors and reattach with the technique we published, and probably also for the ligament. But the truth is that if you make an anatomical reduction, probably that is enough.
Because we were taught, mainly we were taught what René has done in his case when we reduce, when we have the anatomy, we don't need to reattach necessary. Pedro, what would you do, or Vincente maybe?
My opinion is the same because probably if I put K-wires, try to repair the ligaments. Why? Because you need to remove probably 4 to 6 weeks after you put it. Probably you put only a screw, you don't need to repair anything because it could be healing in a perfect position. The arthroscopy in this case is only to be sure that in the proper situation, both ligaments. But I think the two possibilities are fine. It's two-sided. Screws, I don't know, and K-wire and repair, why not?
May I give you an opinion about this? We're talking about anatomical reduction. One thing is bone anatomical reduction or joint anatomical reduction, but sometimes you do have bone and joint anatomical reduction and no ligament anatomical reduction. Sometimes the ligament is a little way from its footprint or the place so it's have a healing potential, but it can heal a little bit away and then become insufficient. So it depends of your evaluation in the joint, or how laxed or how torn it is. So sometimes I prefer to make these reinsertions or little stitches, and this depends so much as well on the post-operative protocol. Because if you move too soon or you allow some kind of mobility, you can also have this.
Of course. So I think that this is a high energy radiocarpal joint.
In the mic mirror.
Any high energy joint articular trauma will bring us this joint stiffness. And if this joint is stiffened, yes, it will not be unstable. So stiffness is the treatment of the instability. So if you are pinning, perhaps the ligament will heal a little bit longer, but the joint will be stiff and perhaps it will not be unstable in the future.
Yeah, but
yeah, we start the fight of the afternoon.
Okay, the last two comments, and then we move on.
But I have a question for Mireia, because your senior partner was always very particular that stiffness and instability can occur simultaneously. So Mark told us this.
Mark has told us that this is a mountain. Here is instability. Here is the stiffness. And if you are here, you cannot be there. And you are there, you cannot be here.
He must have changed.
Okay,
yeah,
last comment or question?
Last comment. I completely agree that probably with K-wires is enough to create that stiffness that probably is enough to stop the instability, but the stiffness is also a problem. So probably with the reattachment, as Gustavo said or Fernando, we can avoid that immobilization or longer immobilization, and we can fight against that stiffness without sacrificing the stability. So that's the reason I think we can use K-wires, but if we can, we have to reattach the ligaments.
Yes, I think it's really depending on the case. One question for me is if we really need to pin it, if we plan to operate it in the next 2 or 3 days, if it's not dislocating spontaneously. If the reduction is still there, I think we don't need to pin it, to make other holes in the bones, and just to go to the OR the next day or the day after, because for sure this is not for the fellow, it's a difficult operation. Okay, I'm very happy to announce now Gustavo Mantovani, and he is presenting his case.
Okay, let's move on. Fortunately, it's not so complicated and not so complex one, but it's interesting because the type of patients is quite interesting. This is a patient, a female, 4 years old, ex-professional volleyball player and very high-level beach tennis players, very popular now in Brazil, beach tennis, and she achieved the be world champions, it means very high level, and has this story of scapholunate dissociation, operated 10 years ago, by other service. I do not have any information about that, but she has some small scar over the SL area, so it was some kind of open procedure, but I don't know what, and reached with mainly complaints of pain in the right side, in the right side of the wrist, in the right wrist, of course, and the radial side of the wrist. But with an excellent, almost normal range of motion. So just before any exams, what can we suspect? Alan, take your victims.
Yes, there are some victims of the left.
Such a cliché to have a beach volley player from Brazil.
At least it's not a jiu-jitsu fighter, no? If a male is jiu-jitsu fighter, is a female beach tennis.
Okay.
In between, I don't know.
Emmanuel from Paris.
Ah, allez la France.
Allez la France. What could you suspect?
It could be recidive
Recurrence.
of scapholunate dissociation. If she has pain when we touch scapholunate
it becomes asymptomatic, keeping her professional sports activity for a long time. So it was like about a year or about of returning of the pain.
Or maybe it's a start of like one. If
Okay.
Good.
Comments about X-rays?
Yes, maybe. I like the last row. I think it's very good to ask questions. Please, just remind us your name, please.
My name is Javier Espinosa from Mexico.
What do you think
what
about
is the
this?
question?
What do you think about? That's why I come. Just it's
okay. The question is
about the
give us some
X-rays.
comments about the X-ray.
Yes. Okay. And I see the line of the radiocarpus is a thin line. It's like arthritis, degenerative arthritis for the radiocarpal. It's like the dissociation between the scaphoid and lunate, and osteophytes in the styloid, radial styloid, and the scaphoid is like arthritis, radioscaphoid, and radiolunate. And mid-carpal, maybe two. Maybe mid-carpal, she have a problem too.
Can you give just a diagnostic about this?
Yes, it's radiocarpal arthritis, dissociation, scapholunate
You
dissociation.
can shorten by some letters.
Maybe mid-carpal too is.
Yeah.
Okay.
Maybe mid-carpal.
Please do not.
What about the AA?
Yeah, I just took a picture before you show the X-ray. I took a picture. I sent it to ChatGPT.
Oh no.
Oh, bravo.
Go ahead.
And ChatGPT said that all these elements strongly suggest the natural evolution of chronic scapholunate dissociation toward scapholunate advanced collapse. Probably a mistake, stage 1 or 2, but pain but preserved mobility. So it's not so bad.
Not so bad. Bravo.
Great. Okay, the questions. Okay.
Yes.
Konstantinos from the US.
Yes.
So yeah.
So diagnostic we already have, thanks to the audience and ChatGPT. The next question: what exam do you need or do you ask in order to fulfill your needs or to make it to your decision making?
You probably don't need much, but if you want to, you can get an MRI and evaluate the SL ligament. You can also evaluate a little bit closer the mid-carpal. I would say it's optional. You could just go into to our
Okay, so
orthoscope.
do you ask for MRI or no?
What would you do?
Well, in the US, you could probably get it pretty easily, so I would.
More by legally questions or bureaucratic questions, or by your necessity?
As I said, it's not necessary, but it would be, especially if it's someone like, let's say, workman's comp, we usually get it for objective data.
Okay.
So
May I do a poll? Who would ask MRI as a necessity for decision making?
You know, Gustavo, we understand that in the US they have MRI. It's very easy to get an MRI. So maybe we can ask someone for another country, and I see Turkey or Canada. Turkey, Istanbul, for example. Oh, sorry. After we will ask.
It's even more easy to get an MRI.
Yes, I know in Istanbul it's very, very easy.
Yeah, very easy.
So you get an MRI.
Like maybe 100 or 200 euros, it's easy. So, but I guess a CT scan would provide more data on this case for me.
Even for the cartilage? For
The
cartilage
cartilage
evaluation?
is almost gone, so I don't think I will ask, because there are osteophytes all around.
We have published a paper with Riccardo Lucchetti and Zay. It's called One Portal. We evaluated a series of patients with MRI, CT scan, and X-rays, and then make a decision based on one portal arthroscopy. And we saw that in 30% of the cases, the arthroscopy showed a completely different situation from CT scan, MRI. So I think that for the X-ray is already showing us an osteoarthritis. So legally, you can treat him. And if we are going to do a treatment based on arthroscopy, we can decide.
I think the question is the head of the capitate. We all agree on this crucial question. Is the MRI enough powerful for the head of the capitate? We have just a question over there.
It wasn't a question, it was more a comment. So
Yeah.
in Canada, we don't have access to MRI that easily. And we actually do arthro-CT scans for these patients. So the arthro-CT will allow us to see the cartilage surfaces mainly at the mid-carpal joint to be able to guide our treatment. Because here we're asking ourselves, could we do a PRC? Is the cartilage nice on this capitate? How about the radiolunate joint? Because the lunate is quite dizzy and there's a bit of an osteophyte on the dorsal rim of the radius. So you're wondering if there's also a bit of arthritis at the radiolunate joint, preventing maybe from having a PRC. Where I'm really surprised with this case is the good range of motion, because I would have expected some restricted radial deviation in this patient because of the advanced arthritis. So I'm a bit surprised. But yeah, in Canada, the arthro-CT would help us guide a bit our treatment. And obviously, I do think that in countries where imaging is more difficult to get, I think a diagnostic arthroscopy could be the alternative.
Okay.
A very short comment. A closed fist X-ray helps us not only in ulnar plus, it helps us also in mid-carpal osteoarthritis, because the joint is narrowing if there is osteoarthritis.
Anyway, I think this discussion is very important because we are looking for some answers to decide and to guide our decision making in exactly which kind of procedure we're going to indicate by exams that do not give us the certainty of that. So, especially in cases like this, so with this kind of quality of magnetic resonance, makes literally no difference in our decision making. So it's to reinforce the importance of the arthroscopic evaluation, especially for arthritic conditions in the wrist, where there is several different conditions that we must evaluate, like cartilage, like ligament conditions, and everyone. Another interesting thing on this case is exactly what Eva stressed and what you guys mentioned, that this is a good range of motion. It's very surprising, and athletes used to give us a lot of surprises. So everything in athletes use it because the tolerance of pain is much lower. They used to have motivations to keep going, to keep moving. So it's be aware every time you treat high-level athletes. Okay, so based on that, okay.
Comment or question, sorry. Has anyone been using the nanoscope in clinical setting to diagnose the cartilage? I know there's a group in France that has been doing that under local anesthetic with no traction in the clinic. So this could be a good option. Personally, in Canada, we haven't started using this, but I would like to know if anyone in the room has any experience with the nanoscope.
This is very interesting. I would like to hear as well, but
problem with this kind of management, it's very expensive. We cannot. We know the unit, the team who does this, but they don't have 100 patients because it's not possible. They did a couple of patients maybe, but it's not possible to manage this in our daily and routine practice.
The question is, if you mean, or if you intend to make arthroscopic treatment, I don't see a lot of sense to use to make a pre-arthroscopy and then another arthroscopy. You already have the two. So indications, raise your hands. Oh, sorry, John.
Well, I have a comment. When I told somebody here I was from Norway, say you're a wealthy country, you can afford everything. I would never ask for an MRI. It wouldn't give me anything. But most of the patients are coming with an MRI, asked for by the general practitioner.
And maybe for medical.
For me, this is definitely a case to discuss with the patient. You know there is arthritis. You don't know what to do, PRC or something else, but you know. If you discuss with the patient, if I find this, I'm going to do that. If I find that, I'm going to do this. And if the patient accepts that, just go ahead and do the wrist arthroscopy. Not a diagnostic, but a therapeutic as well, so you have to continue. That is what I would do.
Yes, exactly. We have online.
We have a
question.
question online, and I should have the same question because it's interesting regarding the wrist innovation, because you have a full range of motion. We have the captors, the sensor captors were still working, and she's complaining about the pain and not complaining about the stiffness. So she's young, what not just removing the sensor and keep on going. It's quite common in Europe, in France. I have own experience on this, and I think you can cope with some drawbacks for a couple of years. So what is your feeling regarding this indication?
Would be my first option because she
the queen of proprioception.
No, because she doesn't have any proprioception yet, because it's arthropathic.
Or maybe she would be worse if she was not using the proprioception.
Okay.
So strong muscles, dynamic,
But
stabilizers.
if I do any intraarticular procedure, perhaps she will not have a range of motion, full range of motion and strength.
You broke my heart.
And she will not be able
I
to
never
do
not from you.
tennis.
Mireia, so Mireia, to be clear, you propose a denervation. But the main problem with denervation is that we just solve the symptoms. We don't solve the problem. So there is an ineluctable evolution.
But now she's 40. She wants to play tennis and on the beach. She wants to have good photos, and perhaps in 10 years
I know.
she will.
And what if And what if it evolves to like 3? And what if if the indication would be more invasive in 10 years? Do we explain this to the patient?
Okay. We have a comment here.
Okay, go ahead.
Here. No, first. No, sorry. You was first.
Well, I've done a few of these with denervations, but in my practice, I have found that adding styloidectomy to the denervation gives better pain relief and better range of motion. And they seem to last for quite a few years.
I think Gustavo Gomez is trying to speak. It has been 5 minutes.
Okay, let's do a pool. Okay.
Sorry. I think that this is the case that if I have a long talk with the patient, I will offer to this patient a scaphoidal reconstruction. Because in many cases, this is very, very controversial, but in many cases, after we do, indeed I have many cases like this one, like that I just do synovectomy, I don't do nothing in the bones, and patients do very well for many years, 6, 7, 8 years. I have many patients about this. And
but we do a tenograft, graft of tendon, reconstruct bone tunnels,
Well, it depends on the finding in arthroscopy. If I see that I have a very nice realignment of the carpus just with the probe, perhaps I just do the most simple thing, which is just a wide capsulodesis, because sometimes we can improve a little bit, not a perfect, but a little bit the biomechanic of the scaphoid. So in this way, we stop the advance of the arthritis, at least at the radioscaphoid joint, and so the patient
Stop, no spoiler anymore. Okay.
I will help, sorry Gustavo, I will help my friend Gustavo Gomez. It's more or less the same principle of, it is a conservative, definitive treatment. It's a mix, and that is the principle of the interposition. Because when we do And radiocarpal interposition, we associate a stabilization of the scapholunate space, and the patients are improving. It is a combined.
So we are running out of time. Let's move.
Okay. Go.
So just a quick question. Raise your hands. Who goes for arthroscopy evaluation and choosing any salvage procedure? Salvage, carpectomy, for corner. Denervation.
No.
Okay, I got it. Arthroscopy and scapholunate reconstruction. Okay, so it's very interesting because I think arthroscopy is changing completely our way of treating and decision making in cases of arthritis. So we started the case with the arthroscopic evaluation. We started to make this the cleaning. You see there are a lot of free bodies inside. So every cause of pain of this patient, synovectomy and so on. Of course, the arthritis was terrible. Of course, the styloid probably was the worst impingement area. So we make this dissection of all these free bodies, of all these osteophytes, and was able to step by step making this cleaning of the joint. I let you see a little bit of the steps. This is our big friend, the pink needle, to make the dissection of the insertions, and then finally removing the osteophytes. We can evaluate all the conditions of the cartilage, where the cartilage is okay, where it's not, and finally to take this decision. The question is a very exceptional case. The patient has a full range of motion. It's very active. So, okay, I agree the denervation is very considerable. But philosophically, I am a little against the denervation, except in the very extreme and exceptional situations. So, as Gustavo mentioned, sometimes you find some conditions that you can provide an increase in the stability and the biomechanics of the wrist by the new methods we have today without so much morbidity. So we do not need anymore some complex and risky reconstructions. So, okay, you're going to invest and risk so much in a wrist with this kind of arthritis. I'm not okay with this. But if I do a soft tissue, simple and fast procedure that can add some stability, increase the biomechanical, maybe postpone the evolution of this collapse progress without morbidity, I can try to preserve and I can try to postpone a more definitive and a more restrictive procedure in this case. So you're seeing now all the cleanage. You see the amount of osteophytes and free bodies involved. So just cleaning this, we can expect, as Gustavo said, and I shared this experience, just cleaning many times, you can win a lot of time of good function and good results to the patient with a minimally invasive procedure. So finally, we made the supracapsuloplasty, the technique you already know, variation of Gustavo. There's a tendency nowadays, Mark Ross and the guys in Australia also are doing other ways of application. So we can deal without a lot of morbidity and risk and increase the biomechanics of the wrist. And then finally doing the styloidectomy and trying to solve the main causes of pain. This is, sorry?
Hank needs to leave, but he wanted to make a short comment.
Sure, sorry. Go ahead. I'm not here.
Sometimes we have a patient, we take an X-ray, and we actually see an X-ray like this, and the patient is not painful at all. So, I mean, I feel we are treating very much the X-ray. I'm a little bit in the camp with Mireille. I think if we do a block, and she's pain-free, she can actually do whatever she wants to do. Any other procedure you're doing, she may not play at the same level anymore. So I think, I think with a PRC, probably her wrist will be much stiffer, and maybe she can't go back to the level. So we've had athletes similar, and they will just want to go back to their old level. So just a short remark instead of treating very aggressively.
Okay. So this is how it looks like pre-operatively. Post-operatively, we could increase the congruency and the contacts and the biomechanics of this wrist. We can preserve the main anatomy and the main articular surfaces. Of course, there is arthritis, yet it can be a problem in the future. We remove the main sources of pain, above all the radial part of the impingement. We can see how the scaphoid position improves. It means you're going to have a better surface area, better contact over there, so probably a better result. And this is just 2 months after that. This is how the patient is. As I mentioned, this high-level athlete has a very low pain sensitivity, and she's very happy with this palliative maybe surgery. And I bring this case because I think it's very out of the box and something that wrist arthroscopy can provide nowadays.
Thank you. Thank you.
ChatGPT answer for the treatment.
So, in the meantime, Mark, you can prepare your computer and ChatGPT give us the solution.
Yeah, so the preferred option for ChatGPT is PRC or arthroscopic conservative treatment, depending on cartilage status. So PRC if the cartilage is good, and for corneal fusion if it is not. So I asked to ChatGPT, is it possible to perform these surgeries under arthroscopy? I mean, those two indications. He said, no. Sorry. And then, last one, I asked, is it possible to, why not a simple styloidectomy? Because this works. And he said, arthritis restricted to the radioscaphoid lateral compartment, you can do it.
Okay. Okay, thank you. So we have at the end the solution. Mireia?
So the problem with ChatGPT is that the patient will consult ChatGPT before coming to the office. And he will say, oh, ChatGPT told me that you have to do a PRC. And you are thinking that you do not, and we have a conflict here. This is the main problem.
It's like when the patient comes from a second opinion.
Yes.
So ChatGPT is the first opinion, you are the second opinion, and you can tell to the patient, ChatGPT is right or is wrong because of this.
And you can go to be operated by ChatGPT.
Till now it was Dr. Google, and now ChatGPT is thought to be cleverer than Dr. Google.
Actually, it is cleverer than us.
Yes. But I think it's a little bit like to do the MRI just for legal reasons. I think it's really something we need to be careful not to give too much food to the lawyers and advocates. So we really need to do it if we need it, and not because maybe a lawyer can jump out of the box and said why you didn't have done an MRI. And I think it's the same with the ChatGPT, but for sure they will come. Okay, it's a great pleasure to have Mark here, and he has the last case for presenting. We are very interested. Thank you, Mark.
Thank you. So this is a 58-year-old farmer who farms cattle, self-employed, no significant medical history. And 6 months prior to referral to our service, he had a severe hyperextension injury to his right wrist while birthing a cow. So it's a fairly typical mechanism of injury in Australia. Immediate onset of central dorsal wrist pain and swelling. He was treated with a neuromuscular rehabilitation program. This was probably one of the early articles on this, and it's certainly worth trying these sorts of rehabilitation methods for these patients. However, he had ongoing pain over the central dorsal carpus when gripping and had a lot of difficulty continuing to work. These are his radiographs, which are 6 months after the injury. So to begin the discussion, what are the key features of these radiographs?
So we have some participants to didn't say anything. They are just here near me. Please, who wants to just to give your opinion on the X-rays? Huh? So if you can give us your name, where you're from.
I'm
please.
Anna Rosa. I'm from Italy. We can say a space between a scaphoid and lunate, and this is the deformity of the lunate, and a dorsal subluxation of the scaphoid at X-rays. So maybe 6 months ago he had scapholunate dissociation.
Yep, very good.
Thank you.
So
Thank you.
Certainly, the key finding probably, we believe, in terms of ongoing symptomatology is the dorsal scaphoid translation. Lunate is extended and the scaphoid is also pronated. Do you think that this is his first injury to this wrist?
What do you think, please? Do you think it's the first injury of the patient?
No.
Why?
Because of the cows he has. I think maybe in Australia they have bigger cows than in Switzerland. So.
Yeah, and he doesn't complain very much. Yeah, I think that the cystic change in the scaphoid, which suggested to me that maybe it's not the first injury, and on the lateral there are some indications of some cystic change in the lunate as well. So, any other investigations?
Oh, the left side is really silent for the moment.
I want your opinion.
Hi, Mandala from the Netherlands. Well, you could opt for a CT scan just to see how the bones are affected, if there is an cyst formation. Yeah, I think I would first go for a CT scan.
May I maybe ask Mohammed, for example? We haven't heard you. Can you remind us,
I am
please?
Mohammed from Saudi Arabia. I'm doing hand surgery fellowship there. I think for this patient, I will proceed with MRI, checking for scapholunate and other ligamentous injury, since I think it is a recurrent injury, so it's not isolated scapholunate, maybe other ligaments injured. And I will rely on my arthroscopic assessment for any cartilage defect as well.
Okay, so we want to talk. The MRI, I was very kind to the participants and put some green marks on the MRI, but can we have some commentary on these findings?
You, my friend, can you comment the MRI? Alessandro from Italy, what would you have to say about this MRI?
Mohammed, you were very... Mohammed has an answer. He wanted to go on with his first answer.
Yes, I can proceed, yeah. We have a coronal view and axial view here in MRI, which shows there is a bone edema and lunate, the radial aspect of the lunate, which is highly associated with the scapholunate injury, which is chronic, and there is high signal intensity as well in the scapholunate interval. In the axial view, we can see the most affected part of the scapholunate, the volar aspect. Yeah, that's all.
But do you think the gap between the scaphoid and the lunate is just limited to the volar aspect?
No, it's more in its whole dorsal and volar, but the widening the volar is more than the dorsal as well.
And what about on the coronal view? Are there any other important ligaments that you can see on that view? This is always a very good view for assessing some important capsular ligaments, and this slice is through the volar aspect of the capsule. So who would like to suggest what my green arrow is pointing at?
Hi, this is Andrei from Romania. This looks like a rupture of the radioscaphocapitate ligament, actually, with interposition between the two bones.
Are you 100% sure about the radioscaphocapitate?
Anyone else?
Not 100% sure.
Mark, do this some combination of different injuries. You see something around the DRUJ as well. We see the CMC joint with this huge arthritis and complex global ligament compromise. Some systemic problems may be suspected, I think, in this case, or calcinosis or like that. You know.
He has had lots of injuries, but he's particularly focused on the wrist, the particular dorsal aspect. So, Yusra.
Likely the long radial lunate ligament.
Yeah. So, is there a pointer that we
Yes,
can?
you can write directly on the screen on your right side. On the right side, yeah.
So, I don't know if it's no.
Ça marche.
How does it work? Draw. Okay. So here is.
Yes, we see it.
Here is the long radiolunate. Radioscapha capitate's usually a bit more in this direction, but there's a very high signal in the long radiolunate, which we know is one of the important structures involved in problematic SL instability. But we have some more MRI pictures, so we can pick on some more people.
Here. What's your name?
I am Lisha. Something going on in the Druch, high intensity in the TFCC region, SL widening, cystic changes in the scaphoid proximal pole. Don't know.
Yeah, that's pretty much.
Yeah. So, and then this area here, is it working?
It is.
Here.
It is very furtive. You need to do it multiple times.
You can see, normally the capsule should be attached to the lunate. Here is the DRC, and somewhere up here is the DIC, but neither of them are anywhere near the dorsal lunate, so this is a major capsular separation from the proximal row. So we've done that. So treatment options. What I can tell you is that he has absolutely no interest in partial fusion. He has consulted Dr. ChatGPT, and he didn't like the description of the complications of partial fusion. So, and he wants something that has low risk and he can return to work quite quickly. So,
anyone has treatment options here?
You have a question for him. Do you think that this is reducible? These misalignments are reducible. So perhaps instead of an MRI, I would first went to the radioscope to see if all these misalignments are reducible to decide which is the treatment.
I guess there's two things that I would comment about that. The first is that you can do particularly just radial and ulnar deviation views to see if the scaphoid will become closer to the lunate. But the other discussion we have is that everything should be reducible eventually if you are familiar with arthroscopic mobilization. So rarely anymore do we see truly irreducible instabilities.
We have a volunteer here for treatment option. Could you just remind us where you're from? And
Hi, I'm Alexandros from Greece, but I live in France and I work in France. What was his age?
What was her age? Yes.
Her age.
57 or 58.
57. We could do an arthroscopic evaluation of the cartilage, as we saw in the earlier patients, and to evaluate the consistency of the TFCC and the cartilage in the scapholunate and the radiocarpal joint, and see if it's reducible.
So he has a 10 millimeter diameter lack of cartilage on his proximal pole of his scaphoid, but otherwise the cartilage in his wrist is preserved. Gustavo?
I think that the most important study to check before the arthroscopy can be an X-ray in lateral view in maximal flexion and maximal extension. And you can see then if the lunate can go to a neutral position, because the problem here is that you usually have fibrotic bands between the radius and the dorsal capsule to the lunate in extension, so it's very difficult to get it. So if you get lateral view in maximal flexion, you can see the neutral position, and in maximal extension, you can see if the proximal part of the scaphoid go back to its facet. And I would offer to this patient to, taking into account what you said, a scapholunate reconstruction. But I want to do a stronger one, not just a capsulodesis.
I mean, I accept the utility of the X-rays, and we use them as well. We have 5 dynamic X-rays with radial and ulnar deviation, clenched fist and flexion and extension. However, it doesn't change my management, because if it's not mobile, I will make it mobile with arthroscopy. Yeah.
I have a question regarding a possible treatment, considering the fact that she does have a damage to the dorsal intercarpal ligament, also to the long scapholunate. Is the round block technique a proper option for this kind of damage? Is it applicable to a ruptured ligament, or only if the DIC is okay from a...
So unfortunately, Andrea has left, but the concept of a dorsal and volar capsulodesis is a reasonable one, but and there are many variations on this theme, but I think that potentially has a role. The problem is that, our belief is that if the dorsal capsule is completely separated from the proximal row, either on lunate or scaphoid, then you are better to guarantee your reattachment or reassociation of the capsule using an anchor. And the anchor will be wherever it's separated, in the scaphoid and the lunate, or just in the lunate, depending on your arthroscopic findings. And then that forms the basis of your capsulodesis.
Mark, I guess that I agree with you, and I guess that you have to restore this bare zone, especially over the lunate, and you have to restore all the footprint of the DIC. So just Gustavo say, it's very important to release, because sometimes this myalignment is like having a contractor. I have to release very, very well if you looking for a success in your technique that you use to repair. If you don't release very well, maybe your technique fails.
Yeah, absolutely. So these are obviously the main options, and he was not interested in partial fusion, arthroplasty, or any of these things. So what did we do? I guess we can now move on to our solution. So we performed a volar plication, and we use a long radial lunate plication arthroscopically. And then we did effectively the same as supracapsuloplasty. So a transverse capsulodesis, which is a mid-carpal ultra-wide capsulodesis interlocked with a radical which uses an anchor in the lunate, and it plicates the DIC and the DRC. So this creates a two-planar plication of the capsule, similar to the capsuloplasty, but with an anchor. We did not do a volar STT reconstruction, and this is probably one of the more controversial questions, is does volar STT pathology exist? And I think it's probably the most black and white division between people in this room. We don't know the answer. My experience with the STT is that it's the most difficult joint for me to identify and to evaluate arthroscopically. I can't reliably see the volar ulnar STT capsule arthroscopically, so we tend to imply what's happening through the kinematic changes in the carpus and with the MRI. So in this classification that we published earlier this year, the scaphoid that subluxes dorsally, so it pivots around a stable distal pole, has a DIC problem, but the volar STT is intact. So we published this with Margaret Fock earlier in the year, and type 1 is the less common, which flexes distally with a stable proximal pole, suggesting volar ST. Type 2, which is what this case has, is DIC with an intact STT, and then type 3 where it flexes distally and subluxes proximally is a type 3, which is the worst and has volar, ST and DIC. So we traditionally just told the scaphoid flexes, but not all scaphoid flexion is the same. They are different types associated with different combinations of ligament pathology. So with this treatment, he returned to work at 12 weeks, and he had a fairly rapid improvement in his scores. And this is his post-op X-ray at 6 months. And I think the most important thing is that we were able to correct his dorsal scaphoid translation. And there's plenty of literature now to suggest that's the most important thing to correct, not the gap, but the dorsal scaphoid translation.
Please, could you remind to our young colleagues here why, in your opinion, the gap is not the most important to follow the patient after?
Because it's more the reverse, is that the problematic pathology is the dorsal scaphoid subluxation and the pain that comes from shearing of the scaphoid on the proximal row. And probably the second thing is the extension of the lunate and the dorsal migration of the capitate. And of course the capitate and the scaphoid move together. So when the capitate moves dorsally, the scaphoid moves dorsally. None of these things are necessarily impacted by the gap.
Thank you.
And this is the mooring line concept. And a lot of this came from our initial publication on traumatic instability. But the key thing is that the restraints for flexion or extension of the lunate are the same whether you're talking about dissociative or non-dissociative instability. And you can look up the radical procedure which we use to anchor the capsule to the proximal row. Probably more interesting is this publication by Nick Smith just 2 months ago, which is using the mid-carpal ultra-wide. So this is a technique that Nick and I have been using for quite a number of years, where you do your capsulodesis entirely through the mid-carpal joint, and you use a panoramic, so it's a wide 6U portal which gives you a view of the whole proximal row simultaneously, so you don't need to move your camera. You put the scope in one place and then you can do the whole capsulodesis. And that's generally the tissue bite that we use for this wide capsulodesis, significantly wider than the original capsulodesis. And this is the Merlin, which is the volar capsulorrhaphy, tightening the long radial lunate. So that's just to show you, this is the effectively what we do is place the sutures around the long radial lunate ligament arthroscopically. And one last thing is this just because it's very interesting. This is a Merlin. We pass a suture into the mid-carpal joint. We withdraw the needle outside the capsule and then pass it back through the origin of the long radial lunate ligament and retrieve it through the 1-2 portal. And then we go back into the mid-carpal joint and pass the other end of the suture from the mid-carpal through the diastasis and into the 1-2 portal. So we now have a suture which is going from mid-carpal to radiocarpal around the long radial lunate. We exchange it for a non-absorbable suture, then use a sliding knot. And if you watch the scaphoid, you can see the ulnar translocation correct as you tighten the knot. And so that gives us a very powerful volar capsuloplasty. So, yeah, I think that's probably enough. Thank you.
Thank you. Shiab, you don't know? We don't have any questions? Okay.
Thank you very much. There are questions, comments? Everybody agree? Philippe, ChatGPT, no?
Yeah, I asked to ChatGPT and he said, I don't know, ask to Mireille.
I have a question to Mark. Mark, do you think if you do only a dorsal reinforcement in this kind of cases, do you have experience with only dorsal reinforcement in this kind of cases? How do we know that the volar reinforcements is necessary here?
Because if we look at all of the published data, including from your unit, the EWAS-5 has the worst results with purely dorsal capsulodesis. And so this is a EWAS-5, and for me, addition of some form of volar capsulodesis allows us to extend the indications of arthroscopic stabilization.
It was an intentional question to explain to our young students what is the, if we try to sum up the main indication preoperatively on translocation of the carpus, could be the key point for you for the indications,
So the ulnar translocation and significant extension of the lunate, radial lunate angle greater than 30 degrees, and also on the MRI, if you are used to looking at the MRI and you have a good quality MRI, you can see the signal change in the long radial lunate ligament.
And another intentional question: what if we don't associate any dorsal reinforcement procedure?
If you don't
associate just no dorsal reinforcement associated, we do only the Merlin procedure.
I've never done that, so I don't know. It's always an adjunct to dorsal capsulodesis. Yeah, so I think that you have to do both dorsal and volar.
Okay. Thank you.
Okay, thank you.
Thank you,
everybody.
Thank you. And thank you to the participants who were really dynamic and they really participated. They joined the discussion. Thank you.
So thanks to everybody. Have a safe trip home or a good day or evening in Strasbourg, and see you next time and online or in the next course. Thanks a lot.
Bye-bye. Thank you.